All right. Hi, guys. Can you all hear me? Just let me see. Okay, right. Thank you. All right. So as you can see, this will be recorded. And I'll talk more about that later. Hopefully people will still come. Oh, okay. I'll continue admitting them while I continue. Okay. Can you let Jasmine back in? She's been kicked out. Kicked out. Oh, well, we'll ask her to join again. I don't see someone in the waiting room at the moment, but if she still can't come in, let me know. Right. I'll start. So just like to something to before we start. So this is mainly a mock session. This is not a teaching session. I do have some explanations or some answers, and if it's particularly important, I will have some explanation slides. But then this is the main focus is on a mock, so I hope you guys have the right expectation for it. So don't worry if you don't know anything. Well, you probably will because the questions I've included are not that hard, hopefully. And if you if you don't know anything, then well, it's good that we have this mock then, so you can go and revise. And about the resources, the recording, all of this will send out once the feedback form has been collected. So I'm seeing like 160 here right now at Zoom. If I get 160 feedback forms, I will send out the YouTube link. And when I get over 200 feedback forms, which is the number of registrants, I will send out the resources and also the notes, which is not in the Google Drive yet. Yeah, so I've also noticed that some of you reflected to me that you find some questions particularly hard. So I've highlighted them in blue. So if you're just aiming for a pass, you probably won't need to know it. But if you're aiming for like distinction, then it would be good to know as well. Yeah, so you don't have to mind about this QR code. I'll give it to you at the end of the lesson, of the mock. And there will be a short break in the middle, just so that everyone can get a just drink of water or something, go to the toilet. And some ground rules, just please be active. If you're struggling, just let me know. Let me know how I can help. Like if you want me to be slower, quicker, or anything, just type in the chat. So I'll be using a Zoom poll because Kahoot no longer works for more than, it's still Ramadan. Wait. Oh, okay. So you can't drink or you can't eat. Sorry, I think you can drink, right? Sorry, I'm not too familiar with it. But anyway, I'll give you a short break in the middle just to rest you, just for resting a bit. So I'll be using a Zoom poll. So how it works will I'll just show you once. So the Zoom poll will be like this. Hope everyone can see it. Then you can choose your answer. Yes, like that. And then I will end the poll and I can share the results. And you guys can all see it. So if the Zoom poll obstructs your view, then you can actually close it first. And you can reopen it and participate again by clicking the three dots. So it's completely anonymous. So I hope everyone joins in, chips in, so we can know what everyone chooses. We can know what you guys are struggling with, so I can explain a bit more if I have time. Yeah, that's all. So let's start. Yes, as before, the resources and the notes that I have prepared for you, and also the PowerPoint will be on the Google Drive. However, it is locked for the moment and will be unlocked when there is enough feedback forms. Yeah. Okay, so some of you asked me for a brief discussion on the testable content in Sem 4. To be honest with you, when I had my semester 4 exam, it was during COVID, when COVID struck. So I had it online. I'm not sure if it is same as what you will have in the coming exam, but if it is so, I noticed a lot of more clinical questions. So more like clinical interpretations of some lab reports. There was a question on an X-ray. There were some questions about liver function tests. One question about acid-base calculations, and all these are quite clinical stuff. So you still have to know your physiology, anatomy, and pathology, and also pharmacology, of course. But then there's a little bit more of this chemical pathology that you might have to know. Do you need to know the normal ranges? No. You don't have to memorize that. This will be clinical stuff. So don't worry. Yeah. Let me just admit this. Saria. Okay. Oh, Saria. Okay. Right. So I'll be covering most of this. However, for anatomy, because it's mostly your anatomy workbook, I won't be doing much on it. But what you must know would be, well, maybe the muscles during mastication, swallowing, the blood supply of the stomach, especially, and the esophagus, because for the varices, and also maybe the detrusor muscles and all the the bladder muscles and all those stuff. That would be some important anatomy. For pathology, I will cover a bit, so you don't have to worry. And I will also lead you through the liver function test because some people seem to struggle with it. Yeah, and I still have a couple of BSS, EBM, and ethics and law at the back. Yeah, so let's start. So originally the flow was this. However, like in the feedback form that I collected, most of you wanted more on the liver function test and other stuff. So the flow will be like this now. I'll cover the ones that you want me to cover first. Yeah. The online ones used progress test banks for questions for the same tests, which, okay, right. Thank you. But anyway, I'm covering what I think you should know in Sem 4. So hopefully it doesn't matter. So first, I'll cover the hepatic, biliary, pancreatic systems. So a brief description of the liver function test. They're not actually assessing their liver function. Your liver function, there's a lot of functions, like synthetic functions of clotting factors, protein, lipids. There's also detoxification, such as those drugs, paracetamol, and those stuff. So your liver function test actually is not really an assessment of your liver function. So what do we measure? We measure the liver enzymes that are normally in the liver cells, hepatocytes, or maybe in the bowel system. So these are AST, ALT, ALP, GGT. These are the four main enzymes that you should know about. Yeah. So you might have a lecture on it by my PBL tutor, but I found it a bit confusing. So I'll talk about it a bit more. So basically what you need to memorize and understand is that AST and ALT are enzymes that are present in hepatocytes. So when they're damaged, they will be released into circulation. And so you get an elevation of these enzymes when there is a hepatic damage, hepatocellular damage. And for ALP and GGT, they're in the bowel system. And if there's obstruction, they will leak into the plasma as well. So you get an elevation when there's bowel obstruction. So a hepatocellular damage picture or a biliary picture. That's the main focus. This you must know. All right. So as before, if you have any questions, feel free to type. So what types of liver derangement are there? This would be a bit more clinical. However, it would be good to know because it will help you with interpreting the liver function tests. So the liver derangements can be divided into hepatocellular damage and also biliary obstruction, these two main types. And for the damage, you can just go and read about it. It's pretty common sense. For example, there's liver infection leading to inflammation, like for example, by hepatitis viruses. There might be like tumor and malignancy, like hepatocellular carcinoma or some metastasis from others, like colorectal cancer. There can be also toxins like paracetamol, as it is cleared by the CYP enzymes. So yeah, all of these are hepatocellular damage. And as before, what enzymes will be raised when there is all these diseases? Well, AST and ALT. So ALP and GGT are raised when there's biliary obstruction, and the list is here. You can further divide it helpfully into prehepatic, hepatic, and posthepatic. For example, prehepatic would be hemolytic anemia or other hemolytic causes. Hepatic could be like a malignancy in the liver that obstructs the bowel drainage. Posthepatic could be like gallstones and all those parasites, for example, or some extrahepatic tumors. Yeah. Well, let's start with our first question. Let me open the poll. Remember, you can open. Wait, let me open it. Relaunch. All right, you can choose now. And if it obstructs your view, just close it and you can open it back by pressing the 3 dots on the right upper corner. So patient presents with weight loss, jaundice, and easy bruising. So weight loss is actually a constitutional symptom. Liver function test shows raised AST and ALT, which are what enzymes? Just think back to the slide. And mildly also raised in ALP and GGT. So what is the likely diagnosis? So AST and ALT are the hepatic enzymes that are normally in the hepatocytes. So what happens when they are raised in plasma? I'll give you 100 answers already. I'll give you a bit more time to think. Don't worry if you don't get this right, because this is quite clinical. It is just to illustrate how we use the liver function tests. Right, I'll just end it here and share results. Hopefully you can see it. So most of you chose C, which is the correct picture because this is a correct answer. This is a hepatic predominant picture because AST and ALT, as I stress again, they are enzymes, liver enzymes, and released when there is hepatocellular damage. And ALP and GGT are released when there's bowel obstruction, such as biliary cirrhosis, parasites obstructing the bowel ducts, or heart failure is actually a post-hepatic cause. Anyway, right. Second question. So just have a read. I'll relaunch the poll. When it's say likely diagnosis, should we take into account how likely? Well, such as if a cancer is rarer than, okay, I'll post the question out. I hope everyone, like if you have a question, you can send it out to everyone, so I don't have to read it out. Anyway, well, it depends. For example, if you're working in the hospital, actually your disease would be skewed. The epidemiology would be skewed because you won't, you would be less likely to see a flu, and you might actually see a lot of cancer patients if you're working in the oncology department, for example. So when you take into account epidemiology, it depends actually. But usually in exams, they would give you some very easy, straightforward questions. So just stick with your gut or stick with your liver anyway. All right, I'll end the poll. A lot of you chose E, so that is actually very surprising because I wasn't expecting you all to know it, but that's good. So let me just close the poll for now. Okay, yes, pregnancy. So why is that so? Please don't. Okay. So liver function tests. Oh, you can't see the poll for some reason. Well, I'm not an IT nerd. I'll try again later. If it's still like that, just let me know. Liver function tests, they're not really specific. So they can be affected by a lot of different, what was the correct answer? Oh, it was pregnancy. I highlighted it here, pregnancy. So ALP can be raised in pregnancy. Why is that so? So ALP, there are a lot of different production sites. For example, the bone and the placenta, and also the liver, of course. So these are called isoenzymes. And for example, if you have a bone tumor, it can also cause a raised ALP. If you are pregnant and you have a placenta, then you can also have a raised ALP. So this is just to let you know that liver function tests are not really very specific. You don't, well, they won't test you much on this because it's a bit too much for preclinical, but it's good to know. And you can refer back when you reach clinical years, which is not too long from now. would you be able to explain why is it not gallstones here? Because first of all, gallstones, have you heard of the, well, she's a healthy young female and everything else is normal, including GGT. So if you have gallstones, you would expect both ALP and GGT raised. Does that make sense? And she's healthy. She does not show any other signs and symptoms. Yep. So in clinical years, when you see a patient that is young, sexually active, she's pregnant unless proven otherwise. Okay, so for iron cycle, if you have attended my anemia lectures back in year 1, you might have already spent some time on it, then congratulations, you don't have to spend much time this semester on this, as you should have understood it. But anyway, for the main focus, you should know bilirubin. Bilirubin is first originally unconjugated and then gets conjugated. And in hemolytic anemia or other causes like that, or if there's hemolysis, so there is an excess of heme, then you would have a buildup of unconjugated bilirubin. If you have something more liver or something bowel related, then that would cause a buildup of conjugated bilirubin. And that would cause like those tea-colored urine and all those, let's see, and all the other stool symptoms that I suddenly couldn't think of. Anyway, yeah, that's basically what you should know at least. And bile is actually recycled in the gastrointestinal tract because the bile salts are not produced enough in the, by the liver, so they have to recycle it. Anyway, let's continue. Relaunch poll. Which may be found in liver cirrhosis. So when is unconjugated bilirubin built up? It is built up in, well, most likely it would be some hemolytic cases, like hemolytic anemia, where your red blood cells are destroyed too much. So there's release of heme into the circulation, and that heme gets converted into biliverdin, which gets converted into unconjugated bilirubin. And that causes the buildup. The poll is not available to me for a reason. No problem. I will, the PowerPoint still has the answers, so you can still understand, hopefully. I'm not an IT nerd, so I'm not too sure how I can help you, sorry. Yep, okay, let's end the poll and share the results. Hope you can see it. So which of the following can be seen in liver cirrhosis due to chronic alcoholism? So actually the answer is all of the above. So a lot of you chose B, which is not wrong, but well, the best answer would be all of the above. So because I just want to raise a point is that in chronic diseases, the liver function test may appear normal because there's a slow onset, so there's compensation. And also with the chronic liver disease, your hepatocytes die. And when they die, they don't release enzymes anymore. And so, yeah, it can appear normal. And alcoholism can induce GGT raise. Yeah. And macrocytic anemia, if you have done in SEM 2, it can be caused, oh, wait, it shouldn't be, but yeah, it's macrocytic anemia. It is caused by alcoholism as well. Okay, let's continue. So cirrhosis, just to let you know, you don't have to know too much of this clinical stuff. Don't worry. Just to let you know, the definition is here. You can just go read. There are many causes: infective, metabolic, biliary obstruction, and there's this score that we use to assess cirrhosis. But just this for your clinical years. Don't worry about it. All right. So viral hepatitis. This is something that you should know. So there are different viruses that can infect your liver. They can be hepatotropic, which are the hepatitis A, B, C, D, E. There are also other viruses like HIV, cytomegaloviruses, Epstein-Barr viruses. These you don't have to know yet, but they can also infect your liver. And hepatitis B is the most common cause of liver cirrhosis worldwide. And they can increase the risk of hepatocellular cancer, hepatocellular carcinoma development. And you need to know their modes of transmission, which are basically the fecal oral routes and also the parenteral routes. Are AST and ALT? Oh, please message me to everyone. If you're shy, I understand, but if you can, please just message it to everyone. Are AST and ALT not affected in hepatitis? Well, as I mentioned earlier, here, hepatocellular damage includes infection by hepatitis, and it can lead to AST and ALT elevation. Okay. What does parenteral route mean? Good question. For example, sharing injections or blood transfusions. Well, blood anyway, or maybe sexual. Those are parenteral. Fecal oral would mean that you eat something that's contaminated, and that's for hepatitis A and E. And for the rest, they are parenteral. Yeah. And BCD can increase the risk of hepatitis carcinoma. I just forgot to type it here. Yeah. For incubation, don't worry about it. I just forgot to delete it. Okay, so mode of transmission for Hep A. Let me just quickly relaunch the poll. Okay. So airborne viruses and microorganisms are like chickenpox, measles. Fecal oral routes, as a lot of you are choosing, will be the correct answer. I'll end the poll because this is quite easy. Share results. Do you guys have any problems with the pace or anything? Just let me know if there's. All right, fecal oral route. And parenteral, remember, Hep B, C, and D. Okay? Zoonotic means like there is a vector, like for example, mosquitoes, dogs, etc. Okay, Hep B mode of transmission. I will skip that because everyone should know it. It will be sharing needles, unprotected sex, blood transfusion. Interestingly, in the past, I'm not sure if now we still don't have, but when we had blood transfusions, we did not check for hepatitis. So a lot of people got hepatitis that way, sadly. Yeah, let's continue. Okay, this is a bit harder. So don't stress if you don't know this. So there's a blue background. Okay, which would be positive? Definitely, if he was vaccinated. Don't stress if you don't understand, if you don't know this. I don't think they will test you this deep for exams since you're preclinical years, but it would be good to know because you're almost entering clinical years already anyway. All right, I'll end when 70% chooses the answer. Okay, share results. A lot of you chose C, which is correct, and I'm glad that you chose it. So this is the explanation, and you can go read it back later. That I also have a table showing like what proteins or would be elevated or markers would be elevated in what types of scenarios. This would be useful in clinical years, so you can go refer to it as well when you reach clinical years. So let's continue. And this is a bit hard, but they did test me on that in my exam. Doesn't antibodies correspond to anti-HBE? Anti-HBE. Wait, what do you mean by that? Wait, let me just go back and look later. Sorry, anti-H. Anti-HBC. So there are a lot of different antibodies. Let me just stop the poll and explain this poll first, and then I'll go back to your question. And poll, share results. So a lot of you chose B, which is sadly wrong, and hopefully I have saved you a mark in exams. Remember zidovudine, the drugs that ends with vudine, lamivudine, those are the reverse transcriptase inhibitors. If you remember from your HIV stuff, You have to know it this semester as well because there is also hepatitis viral. Yeah, so at least know of these A, B, and C, D. A, B, C, D would be very useful just to remember in exams. Okay, so back to the question, and please don't direct message me if possible. Let me just post it to everyone. Doesn't antibodies correspond to anti-HBC? So these, as you can see in this table, all these anti-HB something, anti-HB something, these are all antibodies, host antibodies. And yeah, I hope that answers your question. And these two are the viral proteins. So when you see anti, it just basically there's an antibody that is anti that viral protein. Okay, and please do not direct message me if possible. I understand if you're shy, but please try not to. Okay, let's continue. Relaunch poll. Excuse me if I don't read the question out. My voice is quite tired. So as I mentioned before, bile is recycled by the gastrointestinal system. So enterohepatic circulation actually refers to the recycling of bile salts. Actually, this is a bit extra knowledge, so I should have given this a new background. It's not very important, so don't worry if you get this wrong. All right, let's end it. Show results. Okay, so let's see. So enterohepatic circulation actually means refers to the recycling of bile salts from the GI tract after bile is released. It is because the liver does not produce enough bile salts during the day and it needs to recycle it. So it occurs mainly in the terminal ileum and also the colon, and it's an active process. So it is not along a diffusion gradient, but rather there's active recycling. Yeah. Okay, let's move on to pancreatitis. Does anyone have any questions up till now? Any questions? For pancreatitis in my year, they did not test me about a lot on that. I'll just cover the most important stuff you should know. All right, let's wait. Let me relaunch the poll. You guys can read the question first. Okay. Exocrine pancreas. I will cover the endocrine pancreas later when I talk about diabetes. Take your time. Incorrect. Remember, incorrect. This is, well, a bit hard, but I would say reasonably within your knowledge. Well, should be anyway. You don't have to know all the answers, all the options actually in the exams. You just need to know which is definitely incorrect, so you can eliminate it, or which one is definitely correct, so you have to choose it. Should I add some Kahoot music as a background to get you guys in the mood? After the break, I'm still recording, so I don't want to disrupt. Oh, please no. Well, oh, okay, okay. Ramadan, okay, no problem. And Paul, let's just talk about it. Share results. So this is all. E should obviously be wrong, so you don't have to know all of this. But something that would be good to know is that as in our cells, are in charge of secreting protein, while duct cells are in charge of alkalizing and also hydrating the secretion from the acinar cells. So option D would be the most important facts that you should know. Maybe also option B. Yeah. Let's continue. Most common cause of acute pancreatitis. I expect everyone should know it. Remember, I get smashed as well. So all of these are causes of acute pancreatitis: NSAIDs, alcohol, chronic alcoholism, gallstone ileus, or gallstones that block the bile duct, and also the common drainage. It can be idiopathic. And ERCP, I hope you know what it is. It is an imaging technique, endoscopic retrograde cholecystopancreatography, I think. Yeah. All right, let's end it. Share results. Can everyone see? Alcohol would be the most common cause of acute pancreatitis. Oh, wait. Oh, sorry, I got this wrong. I highlighted the wrong. It should be gallstones. Sorry, I'm sorry. You guys are correct. I will change it back later. Gallstones. Let me just type it. Right. Okay. Highlighted the wrong one. Okay, let's continue. This is a bit of more extra knowledge that you wouldn't expect if you're just aiming for a pass. So don't worry. So because this is a bit harder, so I just gave you 4 options. All right. Surprisingly, good. It's D, yes, correct. So in cystic fibrosis, you can also get a high risk of pancreatitis. And as PINK1 and chymotrypsin C mutations, these are all causes. Yeah, pan mutation is not a thing. I just made it up. All right. So we've covered HPP and we'll be moving on to endocrinology. Does anyone have any questions up till now? No? Do we need to know much about alcoholism? Well, you will need to know about the addiction models. You will need to know how alcohol, well, at least get an understanding of what alcohol affects your, like what systems is alcohol affecting your body? What diseases does it cause? Like just a general overview of it. If you're very aiming for, if you have a lot of time, you can go also read about the alcohol dehydrogenase, like how alcohol is metabolized in the liver, and how it leads to cirrhosis and also pancreatitis. Yeah. That's for alcohol. In the pancreas, I would say it is mainly exocrine acinar cells, I think. Mainly exocrine acinar cells, I think. It's been 2 years since I read about that physiology, but I think it is exocrine acinar cells. So if you don't trust me, then go check the book. It probably is there. Okay, so for endocrinology, I will be covering thyroid first, and then diabetes, and then there's not a specific case for adrenal stuff, but you touch on it a bit here and there, and also it was also covered in Sem 1. So, and then they also tested me in exams, so I thought it would be good just to give you a bit of intro. And I will be giving you a short teaching session on thyroid right now first, because you guys haven't started yet. Right. For anatomy, I won't be covering here, but you can go read up the slides that I had. I taught your senior last year. Just go read it up. It covers everything. Or if you don't want, just go and refer to your workbook. Yeah. They tested me 1 question on thyroid anatomy in exams. I think it was the fascia lining the thyroid gland. Oh, there's also a Kahoot for the anatomy. If you're interested, you can just go and play with your friends. Okay, physiology. The thyroid gland is actually a lot of follicles, and they are lined with epithelial cells, and they make lumen inside it. So that lumen, that hole, or well, that space contains a substance called colloid, which is a jelly type of substance. And it is where the thyroid hormones and the precursors and all those stuff are stored. For the and the thyroid hormones are usually stored bound to this thyroglobulin. And when they are released, they will break off from thyroglobulin and become released with the help of lysozymes. That's basically an overview of the production. All right, and this is the axis that you should know because it's important for thyroid function tests. So in your hypothalamus, there is the thyrotropin releasing hormone that stimulates the release of thyroid stimulating hormone TSH from the pituitary gland. The TSH is very important. It will stimulate the production of T4 and T3, which are the main hormones secreted by your thyroid. All with me for now? T4 and T3 are very important. So T4 is the most abundant thyroid hormone. However, it is mainly converted into T3 to exert the genomic effects. T3 is also much more potent. However, it has a shorter half-life because of protein binding issues, and it is quite fluctuates widely. So for normal thyroid function tests, we measure T4 and also TSH, but we don't measure T3. Okay, there's also a negative feedback loop, like most other hormones that you've learned about. So T4 and T3, these thyroid hormones will exert an inhibitory effect on the hypothalamus and pituitary. So when there's a buildup or excess of thyroid hormones, it will lead to a decrease of TRH and TSH. So less TSH will be there to stimulate the thyroid, and thus it will produce less. All with me? Let's continue. This is a bit word heavy. However, you should know at least the headings, subheadings, 1, 2, 3, 4. Basically, is there a there's this diagram, like, oh, I did not include it, but you will have a diagram in your PowerPoint in your lectures or any other textbook. So basically, to make a thyroid hormone, you first need iodide. Well, you need iodine, but you uptake it as iodide. So, or is it the other way around? Well, anyway, you need I anyway. So it is a very major component of your thyroid hormone. And so you uptake it in an active process against this electrochemical gradients. So you trap it in your thyrocytes. And this uptake is stimulated by TSH. Then when you have enough iodide, you will oxidize it. The oxidation is not really important for exams. However, the enzymes that catalyze this process is very important. Thyroid peroxidase, TPO. Why is this important? Because there are drugs, anti-thyroid drugs that we use that can target this TPO. And this TPO is not only for oxidizing this iodide, but also for other steps, like incorporating the iodide into thyroglobulin. So it's also catalyzed by TPO, and this thyroglobulin with iodide will form these two substances, MIT or DIT. So mono or di, iodotyrosyl. So MIT and DIT. And the last step to make this T4, T3 would be to couple them together. So two DITs will make T4, like 2 di. So 2 times 2 will be 4. And then DIT and MIT together will be T3. So 2 from the DIT and 1 from the MIT would be T3. That's basically it. So why is it called T3 and T4 is because how many iodide they have. So T4 has 4 and T3 has 3 iodides. Okay, so they are stored, they are still coupled with Tg, and they are stored in the colloid. So that's the lumen of the thyroid gland. When it is time for them to release, it will be lysed from Tg by lysosomes, and it will be released into circulation. Okay. Right. This is a bit information heavy, but it is really important that you understand it more than memorizing it, because it is useful for your pharmacology and also pathophysiology stuff. T4, as I mentioned, is converted peripherally to T3 because T3 is the more potent and active form. So there's this process, 5' deiodination. So here I show you a T4 molecule, and you can see that there are 1, 2, 3, 4 I's attached to it. So how do we make it T3? We remove the I from the outer ring. Okay. However, if we remove the I from the inner ring, it will become RT3, which is an inactive form, and it is by 5' deiodination. You might not be tested in exams, but I would say this is pretty important knowledge, that stuff that you should know as a preclinical student. So it will be good if you can go back and read about this stuff. I won't talk too much. All right, let's go on to thyroid function test. As I mentioned, we routinely measure TSH and free T4. We do not measure T3 usually because T3 fluctuates, and also T3 is mainly converted from T4 anyway, so T4 can reflect T3 levels as well. So we measure TSH and T4. And in terms of which one is better, well, if it is a primary thyroidal disorder, TSH is better because there's this log linear relationship. You can go search it up. There's this graph that you will see and you will eventually understand. If you don't understand, no problem. You don't have to understand it yet until clinical years, but it would be good to know if you have time. Okay, so just some signs and symptoms of various thyroid deficiency or excess. The main ones you should know for hyperthyroidism will be like weight loss, anxiety, tremor, fatigue, and goiter. Goiter is actually present in both hyper and hypothyroidism, depending on the causes and the physiology. For hypothyroidism, it will be the opposite of hyperthyroidism. And you can just go ahead and read it. You won't be tested much in pre-clin, but this is just for your reference. Goiter refers to any enlargement of the thyroid gland. It can be classified into diffuse or nodular. So diffuse means the whole thyroid gland is enlarged as one single unit. And the nodular, there will be nodules, many lumps, and it can be just a single lump, single nodule, or a lot of nodules. Multinodular goiter would be a very common cause of neck lumps. And any thyroid state, including hypo and also hyperthyroid, can cause goiter. It depends. For example, if you have Graves' disease, which is actually an autoimmune disease where there are some antibodies that stimulate your thyroid to produce thyroid hormones, then your thyroid would be enlarged because of stimulation. Or another example would be iodine deficiency. If you do not have enough iodine, you would not have enough for production of thyroid hormones. And so with the negative feedback loop being, there will be less inhibition on TSH. And the excess TSH will stimulate your thyroid, trying to make it produce more. And in doing so, it stimulates enlargement. And so in both hyper and hypothyroidism, you can get a goiter. And this is just an example of how we apply the thyroid function test and combine it with the clinical presentation. You can just go back and read it. I doubt that they will test you on this. All right, this is the important part. The pharmacology would be quite important. So the main drugs that you should know, I've highlighted already. Lithium, it inhibits iodine uptake and also prevents thyroid hormone release. Carbimazole and PTU, propylthiouracil, inhibits the TPO, the very important enzyme that we mentioned. And so it stops the production of thyroid hormones. The rest, when you go and cover the case, you can come back to this slide and read it. And we also have some surgical options for hyperthyroidism. We can just remove the thyroid, and that would be, oh, I typed it wrong, not thymectomy, sorry, thyroidectomy. Let me type it in the chat. I'll replace it later. Thyroidectomy. Thymectomy is the removal of the thymus. That is a completely different thing. Sorry, thyroidectomy. All right. Notable diseases that you will have to understand later when you cover that case will be Graves, Hashimoto, and thyroiditis. So when you start learning, just go and read it. I've included all the information you need to know about it. Just come back and refer to this slide when you start. Okay, I won't take your time too much here. So let's start with the mock again. Wait, let me relaunch the poll. This actually doesn't matter if you have not started learning about the thyroid yet. This is actually a trick question. A trick question. Read the question carefully. Read the question carefully. This is a trick question. You don't have to know anything about the thyroid to get this right. I've been tricked. Okay, happy April Fools. A bit late, but better late than never. Okay, I'll share the results. The majority of it got it wrong. This is a sign, like not a symptom. Okay, so a symptom is something that is something that the patient tells you. The sign is something that you observe from physical examination. So you don't have to, but anyway, this is just to bring you, well, to raise some important symptoms of hyperthyroidism: weight loss, diarrhea, fatigue, and all the stuff. Tremor is actually a sign of hyperthyroidism as well, and you will have to check it in physical examination. All right, let's continue. Shop stops sharing this poll. Next, you can refer it again here. Okay, this is important. True or false? Just choose A or B for A for true, B for false. So when we think of hyperthyroidism, we would think of a very slim, very thin, a cachexia, a patient who has been weight loss, like a lot of significant weight loss. That's for a hyperthyroid patient. But would it have anabolic effects here? Because fat, glycogen, protein accumulation, it is an anabolic effect, not a catabolic effect. Would you expect it in thyroid hormones? Share results. And yes, you would. Thyroid hormones have both catabolic and anabolic effects. So in normal physiological concentrations, it actually is for maintaining the optimal metabolic rate. So it has both catabolic and anabolic effects. However, if it is in excess, then the net effect will be catabolic. And therefore, you would become more thin, you would be, you have weight loss, and you have all those stuff. Yeah, these you just have to refer later. All right, let's continue. Let me share the poll again. Relaunch poll, continue. What is the difference between catabolic and anabolic? Oh, you should know it because you have been taught about the metabolic stuff. Well, I can cover it later when I talk briefly about the metabolic pathways. But essentially, catabolic means using up the energy that you have stored in your body. Anabolic, catabolic would also be like a bit like destruction. So you're destroying the stores in your body and using it up. For anabolic, you're building. What are you building? You're building some energy stores you're conserving more energy, storing more energy in the fat, in the form of fat, glycogen, building more muscles, etc. Okay. If you're still uncertain, then ask me later when I cover the metabolic stuff. Right. Share results. Okay. Yes, lithium. Remember, lithium is a very common iatrogenic. That means drug cause of pseudo hypothyroidism. Okay, and these signs and symptoms are that of hypothyroidism. Yeah, all these jobs you should know of by the end of this year. Okay, let's continue. Don't worry if you don't know it because you haven't learned it anyway yet. But you will have to know it. Okay, very, very quite difficult question. Actually, okay, I'll just tell you the answers directly. Basically, TSH, thyroid stimulating hormone, stimulates most of the processes in the thyroid production. And it also stimulates the hypertrophy and hyperplasia of the gland itself. However, the one thing that it does not stimulate is the penvin. You will encounter it later when you reach the case. This is just to raise it up in advance. Yeah. Okay, let's continue. Stop sharing. I'll skip this. Just refer to it. Basically, nodules can be divided into hot and cold based on the imaging, and cold nodules are more likely to be malignant. All right. Relaunch poll. Wait. Oops. Here. So protein carriers are very important because they can prolong the half-life in the circulation. So it prevents them from being degraded or excreted as quickly. And for the case of T3 and T4, this is particularly important. Right, yes, it's B, thyroxine binding globulin. Sex hormone binding globulin, well, it binds to sex hormones, not thyroid. Albumin binds to a lot of things, but for thyroid hormone major, the main one is B. All right. This is also, I don't expect you to know, but I'm using this as an opportunity to raise this points and facts up. Catecholamines would be like the stuff related to sympathetic nervous system. So would it be elevated, decreased, normal? Would it fluctuate, or you don't even know what a catecholamines? Oh, someone did choose E. Okay. Well, you know now. Come on, guys, just choose your answer. It doesn't matter if you get it wrong. No one knows. Okay, let's stop. Share results. And surprisingly, it is not elevated. So in thyroid hormones, they do not stimulate the release of catecholamines, but then they stimulate that, and they induce the receptors of catecholamines to be upregulated. So there are more receptors for catecholamines, and so there's an increased sensitivity of the sympathetic nervous system. Okay, so you would get those tremor, fine tremor, those palpitation. That is because of the sympathetic stimulation and also the thyroid hormone effects itself. But then there are no increased catecholamines. They are normal. It's just the sensitivity that is increased. All right. This question was tested in my exams. Radioiodine therapy is a treatment for hyperthyroidism. So you would give some radioactive iodine for the patient to drink. And because the thyroid uptakes a lot of the iodine, it will be damaged by the radioactiveness of the iodine, and there will be cell death. And so you will get less thyroid production. However, a side effect would be hypothyroidism. And then if you have hypothyroidism, you would have to take lifelong medications for it. But that is still better than having hyperthyroidism in some cases because it can be fatal and dangerous. All right, the answer is C. Well, this is just no of it. Yeah. All right, diabetes. Any questions up till now? Any questions up till now? No questions. Do you need a break? No. Okay, let's continue with, let's finish the endocrinology first. I'll give you a break. 1 minute break. Okay, 1 minute. Go. 1 minute break, everyone. And if you have any questions, type it in. If you have any questions, feel free to type it in the chat box now. Yes, you will have a break long enough for brewing coffee later. All right, let's continue. Diabetes. I think you covered it already. If not, well, too bad. All right, which of the following secretes glucagon? Make sure you know all these cells and all the things that they secrete. Make sure. We're back to the endocrine pancreas now. If there's an excess of thyroid hormone, will there be an anabolic or catabolic effect? As mentioned in the lecture, or well, as mentioned in the PowerPoint, it is a catabolic effect. Sorry, just give me some time. I'm replying questions. Yeah, so because there's this increased stimulation of NAK ATPase, so you use up more ATP and you become thinner. If there's little thyroid hormone, okay, wait, let me end the poll first. Let me talk about this question first. Share results. A lot of you choose A, which is correct. Glucagon is secreted by alpha cells. Beta cells secrete insulin. Chief cells are not in the pancreas. Delta cells secrete somatostatin, which is important later, as you will come to see during the digestion. F cells secrete polypeptides. Yeah, they are also called PP cells for pancreatic polypeptide. Okay, back to your question on what if there are too little thyroid? Here, you see this weight gain. Okay. Hypothyroidism is basically the exact opposite of hyperthyroidism. So you just have to memorize hyperthyroidism for now and just guess the opposite if they test you on hypo. Okay. As mentioned, the resources and this PowerPoint will be released once I get 200 feedback forms back. More than 200 of you registered, so I expect more, at least 200. Okay, let's go back. DM. Stop sharing the poll. Continue. C peptide. When you're answering, can you just someone answer me and tell me if you have learned DM already, just to make sure. Have you? Okay, good. C peptide. I hope you know what that is because it's quite important. We test it when we're suspecting some insulin-related stuff. All right, I'll end it. Share results. A lot of the majority of you actually chose A, which is sadly wrong. So exogenous production of insulin, there will be no increase in C-peptide. Why is that so? Because C-peptide is actually cleaved away from the structure, from the precursor of insulin. So in order to make endogenous, so exogenous means something from the outside. It is not produced by your body itself. For endogenous production of insulin, C-peptide will be cleaved off. It is called C-peptide because it's a connecting peptide. It connects pre-insulin with whatever, and so is the C-peptide. And so in a situation of increased production of insulin, you should theoretically also have a 1-to-1 ratio of increase of this C-peptide. Okay, so when we suspect someone with, for example, let's see, if we suspect someone with insulin excess, then we will do some investigations, including if we can't find the cause, then we would like even after imaging, we cannot find any causes of excess insulin. Then we can also test the C-peptide, and if it is not raised, but insulin is, then it points towards something exogenous. What is the most common cause of exogenous production of insulin? If imaging shows nothing, it is actually quite funnily self-injection. A lot of healthcare, like nurses or other healthcare professionals with access to insulin, they can inject themselves for a holiday, like to develop signs of like, oh, I'm not feeling well. Well, that's apart from insulin overdose, of course, for diabetes patients. Sean, can you explain this C-peptide concept again? Yes. This structure, this molecule here, this is called proinsulin. This is the precursor of insulin. Okay. And this chain here that you can see, part of it will be cleaved, cut off by enzymes into insulin. The remaining parts contains C-peptide. So if you want to produce insulin, you would have to produce the same amount of connecting peptide as well. You would release the same amount of C-peptide as your insulin. Does that make sense? So if you have an exogenous production of insulin, your insulin is not being produced from your body. It is not cleaved from proinsulin. Then there will be no increase in C-peptide. Okay? If you still don't understand, then go read a book. Let's continue. We launch poll. True, false. A for true, B for false. Let me just close the door. This should be a very easy question. However, from the responses that I'm getting, I'm feeling worried. Oh, and it's sad only 165 people are here. I'm wondering if I shouldn't have let you know that I would be recording it. But anyway, okay, I'll read answers here. Share results. It is true actually. So a lot of you got it wrong, unfortunately. So why is that so? It's because of the incretin effects. incretins are the GLP-1 and also GIP, and they are secreted when there is glucose in your intestines. Okay, and this is actually a very important concept to know. So yeah, just read on your own. So if you give, so comparing OGTT, like oral glucose OGTT tolerance test, oral glucose tolerance test, where you give patients a drink of glucose, 75 grams anhydrous glucose mixed in, I forgot how many liters of water, then it will stimulate the release of incretins. And so you would get a larger increase of insulin. However, if you just give a bolus IV intravenously of insulin, it does not say, sorry, if you give a bolus intravenous glucose to the patient, it does not stimulate the incretin release because there's no glucose in the intestines. So you will get a less rise in insulin. That's why for the glucose tolerance test, we do an oral glucose tolerance test. I hope I don't have to explain the OGTT concept, but if anyone doesn't understand about the OGTT concept, I can explain it a bit. No? Okay, let's continue. Yeah, good. Okay, inhibitors of insulin release, very basic physiology stuff. How many slides are we at? 83. We're almost halfway through, so that's good. I will have a long break when we're halfway. Can you repeat that? Sorry. Yes, incretins are substances that stimulate insulin release. And they're these incretins are released from your intestines. And they're released when there is glucose in your intestines. So when you ingest glucose. So comparing an IV glucose, like, so if you give glucose to a patient, there will be a larger increase of insulin in oral glucose than IV glucose because of incretins. Okay, let's continue. Share results. Inhibitors of insulin release. This is very factual stuff. Just read the PowerPoint. Yeah. Yeah, I won't read it. Just look at it later. Oh, remember to fill in the feedback form because you won't get this PowerPoint unless I get enough. Okay, let's continue. Extended matching questions. Don't be scared by a lot of questions because this is actually a standard question type anyway. This is definitely something that they would test you in exams. %35% responded. Come on, guys. 50%. Come on. Just try. I will reveal the answers when I get 70% participation, which is now. All right, share results. And congratulations, most of you are right. It's grade 2. Well, very factual stuff. Now, second question. Oh, it's so sad that Kahoot is no longer free. It's not fun. So just now, GLUT2 was in charge of allowing the glucose to enter the beta cells in the pancreas. And that way, it can stimulate insulin release. Now, when insulin is released, it will induce something to the cell membrane, upregulate something, so that there is increased uptake of glucose. And the result is, oh, is someone not muted? Let me just mute everyone again. Mute all. Okay, and that result is, let me share results. Good 4, okay? Good 2 is for allowing glucose to enter the beta cells to stimulate insulin release. Good 4 is, hello, Sean Lee, how, I'll explain it first. Good 4 is what insulin induces to be upregulated so that there's increased uptake of glucose by skeletal muscles and adipocytes. Right, and regarding how we are gonna get 200 responses. So as I mentioned at the very beginning, there are more than 200 registered people, and I will give you the feedback form later. So I am seeing 168 maximum participants. And if I get around 160 feedback forms or maybe 150 feedback forms, I will release the YouTube video or the recording to the rest of the people that registered but did not attend. And when once they have finished that video and filled in the feedback form, then there will be 200 responses. And then I will release the resources and this PowerPoint. Okay. You guys still have a bit of time. It's just April. Well, tomorrow is the first day of May. So you still have time. You better, you might have to hope that I get enough feedback forms. All right, let's continue. What does insulin bind to? Is a very common question that is asked in different universities. By the way, this might be the last session that I will have with you guys, because you guys are going to clinical years. And I transferred back to Hong Kong in year 3, so yeah. Let's end the poll, share results. Boom. Insulin binds to tyrosine kinase. So same as those IGF-2, those insulin-like growth factors, which you might have encountered in semester 1, if you still remember those. All right. This would be a bit more challenging, but it's definitely important because it explains, well, it's important in terms of diabetic ketoacidosis. If you have any questions, feel free to type in the chat. If you think the pace is too quick, feel free to type in the chat. If you need some more time, type in the chat. If you have anything, type in the chat. We might have to pick up the pace up. Oh wait, we don't. Yeah, we don't. We're good on time. I'll make sure. Well, I'll try my best to end in 3 hours with a break in between. Sorry, Sean, what was the answer to the previous one? Tyrosine kinase. Just 50 of you participated yet? Can you choose the poll, please? It doesn't matter to me, but I just want everyone to like participate. You learn better that way. And I'm not moving until I get 70% participation. So please just click the button. For some reason, I do not have access to the poll. Can you try? Have you tried clicking the 3 dots on the right-hand corner? Right-hand corner, right upper corner. Okay, never mind. Okay, then it's almost 70%. It's 76, 67 now. Never mind. You don't have to refresh. It's fine. Okay, I'll just stop when like 60 something percent then. No problem. Well, let's continue. Share results. Can you at least see the results of the poll? If you can't, well, you will be still able to see the correct answer, but I just thought it would be good if you know what. Oh, you might try refreshing the Zoom. I don't know. I don't know how to help you. Carnitine shuttle is actually the reason why DKA is more common in type 1 DM than type 2 DM. Hopefully that answers your question that you might have in your learning agenda for that case. So in type 1 DM, there's a complete lack of insulin. Okay. And that complete lack of insulin will lead to a complete disinhibition of the carnitine shuttle. What is the carnitine shuttle? Good question. It is basically the major, how do I explain it? Carnitine shuttle is like, it is a mechanism of sort of the production of ketones from beta oxidation of fatty acids or something. I think. Yeah, I think that's it. You can just Google it or just read a book. It's a bit 2 years from now. I have a fuzzy memory. That's yeah. Okay, so in type 1 DM, you have an absolute insulin deficiency. So your carnitine shuttle is not is disinhibited completely, and so you have a increase in ketogenesis. Whereas for type 2 DM, you still have some insulin to inhibit the carnitine shuttle, and so you have less chance of ketogenesis. And so if you have a diabetic attack in type 1, you usually get DKA. You have type 2 diabetes, you will have a hyperosmolar, non-ketotic hyperglycemia. Okay. Hopefully that answers the learning agenda of yours. Right, let's continue with pharmacology, basic stuff. And this was tested in my semester 1 or 2 progress test as well. So good to know for progress test as well. Quite the examinable side effect, just like how lithium causes hypothyroidism, or in progress test, they keep repeating that live vaccine question. Insulinoma, would that mean ketoacidosis is how about insulinoma? But I'm not too sure what you're talking about. Ketoacidosis. But you won't have diabetic attack if you have insulinoma. You have excessive insulin instead of insufficiency. It's a different thing. Yeah. I'm not too sure because this is not something that we see clinically. I have never encountered a question like this, so I'm not too sure about this, unfortunately. So, well, yeah, continue. Metformin, very notable side effect, lactic acidosis, very rare, but they like to test you on it. This is the, I've included a list of the notable side effects and also the major drugs for diabetes, and you can go refer it later. Okay, let's continue. This is a bit more extra because it is a bit more clinical, and I don't actually expect you to know the reference values yet for preclinical, but this is just to let you know source. Oh, actually, I'll skip this question. I'll skip this question. Can you go back to one slide? I missed the answer. Yes, it is metformin. Metformin causes lactic acidosis. as a side effect. Very rare, but examinable. Okay, so basically these are the reference values that you will have to know in clinical years. You don't have to know it yet. But what you should know about is the concepts of normal fasting glucose, impaired fasting glucose, and diabetes. There's also a normal glucose tolerance, impaired glucose tolerance, and diabetes. So these two concepts you might have to understand, but for the reference, you don't have to remember yet for preclin. Okay? And this is just for you for reference. Okay, let's move on to adrenal. This is the last endocrinology topic we will have before our long break. Does anyone have any questions up till now? No? Okay. Oh, by the way, if you have any friends that you know also registered and you know if they are free, can you just ask them to join? Because yeah, I obviously I spent a lot of time making this, and if you don't come, then it's actually wasting my efforts. So yeah, adrenal. Which does not stimulate aldosterone release. So you can, well, the factors that stimulate aldosterone release are actually quite obvious. So you can just eliminate them and just pick the one that is left over. Oh, this is getting boring and lonely, and everyone. Oh, but no one has questions. Never mind. It just means that I explained too well. That's good, I suppose. Any more answers? Right. To newcomers, so welcome. We're having a Zoom poll for each question. If you want to close the poll and reopen it, just press the right upper corner three dots, the three dots there, and just press poll. If that does not work, sorry, I don't know how to help you. Okay, let's continue. Parasympathetic nervous system. So what states aldosterone release? Basically, the explanation here, angiotensin is stimulated by these two main factors. Decreased ECF volume or blood pressure. It is also less affected, but still affected by the osmolality. But mainly it's the ECF volume. And ECF volume can be decreased because of dehydration, diuretics, hypo-Na, because in hypo-Na, water will follow it. So in aldosterone, the effects of aldosterone will be to conserve Na and also water at the expense of potassium and also hydrogen ions. And so it is great for hyperkalemia. And so hyperkalemia stimulates aldosterone release, which will stimulate more excretion of potassium, and so it corrects that. Yeah, okay, let's continue. This is basically the table. It basically summarizes all the plasma changes, the changes in mineralocorticoids, glucocorticoids, the changes in cortisol levels, the changes in your plasma analyzed electrolytes, the sodium, calcium, potassium, and all those stuff. I cannot go back to the table, sorry. And it also shows you the tests that we have for each individual diseases that you will see for adrenal disorders. It's very comprehensive, and I'm not showing it because in case people just screen cap and just don't, yeah. Yeah, you will have this PowerPoint and all the tables later. Okay, let's continue. Which of the following is not a feature of Cushing's disease? This is a bit more than one, but I just thought to throw it in as well. Oh, and the table previously would be very useful for your clinical years because you need to start interpreting lab results. Cushing's disease. Buffalo hump is a fat pad at the back of your neck, so it makes a hump. Easy bruising and striae formation are due to collagen and other factors which I forgot. It's too long ago. All right, let's show the answers. So this is another trick question. Cushing's disease and Cushing's syndrome. Cushing's disease is actually a pituitary disease. So there's excess release from the pituitary, excess cortisol release from pituitary. Okay, for example, like a pituitary adenoma, that would be a Cushing's disease. For Cushing's syndrome, that usually refers to some exogenous steroidal medication. Okay. So a lot of you shall see striae. That is unfortunately common. A, B, C, and E are all common signs and symptoms of hypercortisolism or too much glucocorticoids. All right. Relaunch poll. Cushing's syndrome, which is a common feature. Hypernatremia means high plasma sodium, high serum sodium levels. Hyperpigmentation, it is usually because of increased ACTH. So in cases of increased ACTH, you would get hyperpigmentation. For example, in Addison's disease. So you have to think back about the feedback loops, the negative feedback loops. Will it have high or low ACTH? Will it have high or low CRH? All right. So the majority of you chose C or E, and the answer is C. In Cushing syndrome, there's excess glucocorticoids, and that has negative inhibition, negative feedback. So there's an inhibition on ACTH and also CRH. So B and D, E would be wrong. In adrenal atrophy, that would actually lead to aldosterone, adrenal, whatever. ACTH? Wait, but have you learned about adrenals yet? ACTH is adrenal corticotropic hormone. Let me type it out. It is produced by the thyroid gland, pituitary gland. It stimulates cortisol production. If you don't know about that, I would suggest you read about it, at least have a basic understanding of it, because you should, over these 2 years, know a bit about adrenals. Okay, central obesity is a common sign and symptom of excess glucocorticoids because induced adipocyte proliferation. Here, we'll be moving on from the adrenal cortex to the adrenal medulla. This is just one question. I made it a blue background because this wasn't explicitly in any PBL case. However, I thought it would be important to raise your attention to this disease, just to get a brief knowledge or just know about this before you start your clinical years. Alternatively, you can think if we are measuring cortisol, if it is something that is related to cortisol, would you have this presentation? If you have thyroid problems, would you have this presentation? If you have growth hormone problems like acromegaly, would you have these problems? If you have a pituitary tumor, what symptoms will you have? We're almost nearing the break. However, I do need to pick up the pace, so let's end it. Right. This is just for a reference. I doubt that they will test you, but this is a very typical presentation of pheochromocytoma, which is a tumor in your adrenal medulla that leads to increase of catecholamine production. So there are more noradrenaline and also adrenaline, or epinephrine, if you like to call it. So why is it classical? It is because of the episodic presentation. It's an episode. If you have like if you have hyperthyroidism, you will have headaches, you can have palpitations, you can have tachycardia and sweating because of the sympathetic stuff. However, it is a constant presentation. For pheochromocytoma, the most classical thing is the episodic presentation, and the VMA is actually a product of the metabolites from NA and A. So just to let you know, you probably won't be tested in SAM4, but yeah, since we're on the topic of adrenals. All right, so let's take a 5-minute break. I think that should be enough for you to brew a coffee. I don't know. I hope so. If not, too bad. And we will be moving on to the GI system in 5 minutes. So it is 3. Okay, I can go back to the order. No worries. It is 10:34 now. We will come back at 10:40. All right, all right. So we're back. Let's start again. Uh, as you can see, we have reached only number 3. However, it is actually number 4, number 6, 7, 8 are relatively briefer. So, how many slides are there? Let me just check. There are. Oh, let me share screen. 1 sec. There are 196 slides here, so we are currently more than halfway. Oh, are we? I think we are. Yeah, we're halfway. Yay. Okay, so let's start again. I've posted the registration form in case someone still is unable to, or someone wants to join midway. Anyway, let's start. GI system. Can everyone hear me again? Just type a yes if so. Yes, okay, good. All right, wait, let me start the poll. Relaunch. All right, back to case 1, or is it case 2? Forgot, I think it's case 1. So the order of this presentation is because I put the ones that you want me to cover most or cover first in the first place. This was tested in my exams. I'm not sure if the lecturer is still the same, but this information was shown in PowerPoint with a blue background. It was quite distinctive. Oh, someone left. What a pity. That's sad. All right, let's send it. Yeah, okay, it is the trigeminal, the facial nerve. So those are in charge of the muscles in your head and your facial muscles, your muscles of mastication, as you have learned in Sem 3. There's also the cranial nerve 9 and 10. So yeah. Oh, sensory component. But yeah, anyway, just memorize it. Wait, I should stop sharing. Right. Lower esophageal sphincter. Which of this is incorrect? So I'm not covering a lot of anatomy here in this session because a lot of it is just factual, and only your workbook would be tested. So I would rather test something like revise with you something that you have to learn about on your own, something that you might have missed. Oh, someone left again. That's sad. Come on, just 53 participating in the poll. Too bad it's Ramadan. I think some Kahoot music is really needed. Okay, share results. D, yes, correct. Very factual stuff. You just read it on your own. It should. Wait, what? Oh, yeah, it should relax on swallowing, so it can allow the food to pass into the stomach. It is normally constricted to prevent the reflux of gastric contents into the esophagus, but not during swallowing. Right, let's continue. So we're moving a bit up, back up again. This is probably one of the very last or second last question on anatomy that we will have. This is quite important. You should know this. If you don't, you will know after this session. And Saria, is that you actually? Like year 4 Saria? Year 5 Saria? Anyway, okay. Sure results. Cricopharyngeus is actually the muscle that's relaxed. It is the most inferior part of the pharynx, and in order to let the bolus pass into the esophagus, it needs to be relaxed. Right, very factual, but testable. So yeah. Right, we're moving back to the physiology of digestion. So which of the following is correct? It is a bit word heavy, so I'll give you some time to read. But yeah. So is it A, 3 phases, caudal phase, gastric phase, intestinal phase? Read carefully. Read carefully. I'm seeing some. Is it B, low pH can stimulate and also inhibit the gastric phase? Is it C, amino acids and peptones in the stomach stimulates the intestinal phase? Or is it D, the gastric phase of acid secretion can be triggered by the smell, sight, thought, taste, and swallowing of food? Or finally, is it E, the first phase of acid secretion or digestion is mediated by the sympathetic nervous system? Wow, I'm getting a very mixed response here. It's like watching a horse race. B and C are head in head. Oh, C is, no, it's B. Oh, now C. Come on, make up your mind. Okay, I'll just stop. Let's share the results. So first, there are 3 phases of acid secretion. It's the cephalic phase, gastric phase, and intestinal phase. Caudal means tail. It's not something that you would expect as the first phase, right? Cephalic means the head. As you might have remembered from Sem 3. And then I'll talk about the wrong answers first. So presence of amino acids and peptones in the intestine stimulates the intestinal phase. That makes much more sense, right? And then the gastric phase of acid secretion is not triggered by this all. It is the cephalic phase that is triggered, okay? So when you, and the cephalic phase is also mediated by the vagus nerve, which is a parasympathetic one. Okay, so B is the correct answer. Low pH levels can both stimulate and inhibit the gastric phases. There are both negative and stimulatory and positive feedback loops that you might want to have a read about. I won't spend too much on the details because wait, let me share the point. Okay. These are all very factual stuff and stuff that definitely you should know as a pre-clin medical student. Obviously, when you reach clinical years, I don't blame you if you forget all of these, but you're still 3 tests away from clinical years. So we're talking about the acid secretion in the stomach right now. So we're talking about the gastric phase right now, not the intestinal phase. So don't mix up some of the terms. Oh, Oh, how nice! Someone sent me sent me an email explaining why they had to leave. Okay, well, there's no pressure for you to leave. Actually, it's just a bit sad. That's all. 50% participation. Can you guys read quicker? It doesn't matter if you get it wrong. Just choose an answer that you think is correct. I'll show you the correct answer anyway. Okay, 60%. Okay, let's do it. Show results. E. All the explanation is here. You can go read it later. So it should be somatostatin in the stomach. Secretin is the one for in the intestinal phase in the small intestine. So somatostatin does not. So enterochromaffin-like cells, ECL cells, do not release gastrin. They release histamine. Gastrin is released from the G cells. G for gastrin, right? Okay. But it does inhibit. What are secretagogues? Did I not say it here? I remember one question. Okay, what are secretagogues? You will know it later. I have another question for it. Okay, wait. Oh, I have a question here. Oh, huh? Oh, well, secretagogues are histamine and gastrin. And as their name shows, they promote secretion. And in the case of gastric acid secretion, what do these secretagogues do? They promote acid secretion. Yeah, okay. I hope you understand that. Let's continue. Wait, next. Okay, Paul, where's the Paul? Stop sharing. Relaunch. Okay, let's continue. These are very factual stuff and stuff that lecturers like to test you on, but are not very useful clinically. Well, I haven't had to know of this in my clinical years up till now. I'm not sure, but anyway, it is important. Very factual stuff for you in pre-clin. Did you say secretin is the main inhibitor in the intestinal phase? You will know later. You will know later. We're still at the gastric. Oh, we're almost leaving the gastric phase. Actually, you will know from this. Wait, did I get it wrong actually? No, I think I did not. My memories are a bit fuzzy, but I think yes, for your question. Correct me if I'm wrong. Honestly, it's been 2 years since I read about this. Okay, let's end the poll, share results. Here. So the main triggers of inhibition of acid secretion are fat acid and hyperosmolality. So it is not, so these are the main triggers. And they will trigger something else, including secretin. Secretin actually inhibits the release of acid from parietal cells. Yeah, the rest of these are correct and very factual stuff that you should know. I don't blame you if you don't memorize everything, but I probably think it would be good if you know about it. Okay, right, let's do some extended matching. These questions are definitely important. You must know of all these cells and everything that they secrete. These are very testable in exams. Make sure you know all of these. When you revise, do not revise according to this PowerPoint, however. This is to raise the possible things that they would test you, but they are by no means the best organized way for you to revise. So when you're revising about, for example, case 1, case 2, digestion, then move from the swallowing, read about the swallowing, and then the muscles during the swallowing process, and then move on to the cephalic gastric and also intestinal phases of gastric acid secretion, and then move on to what cells secrete what factors are inhibitory, what factors are secretory, what do they do? Well, all these stuff you should know. Okay, good. I see a lot of people are very confident in these questions, which is good. Yes, eye cells secrete CCK, cholecystokinin, if I remember the right name. Let's continue. Somatostatin. I briefly mentioned it earlier. You might remember it. So alpha cells secrete glucagon, beta cells secrete insulin. F cells or PP cells secrete pancreatic polypeptide, and that leaves the so really make sure you know all of these cells and what they secrete. At least make sure you know these. All right, 60%. Results. Yeah, these cells of the stomach and duodenum, and also the pancreatic cells secrete somatostatin. What does the somatostatin? What effects do the somatostatin have? Then you should also know about it. Okay, but let's continue for now. Very factual stuff, actually. You either know it or you either don't. So ECL cells, as mentioned before, secrete histamine. G cells secrete gastrin. And these two are secretagogues, which stimulate gastric acid secretion from parietal cells. This is a bit more challenging, but still definitely something you need to know, VIP and GIP. It's from the enteric nervous system. Okay, I think it's the final one. I hope so. It is getting a bit heavy. Should I skip it? Like, just show you the answer. Okay. Yes, chief cells. Did someone choose? Yes, chief cells, pepsinogen. And this is a bit more clinical, but I'll just talk you through it. If you have a patient with epigastric pain following meals, what would be important in history taking? So actually all of it. So history of osteoporosis would, there might be bisphosphonates medication. It can cause peptic ulcers. Oh, we are moving on to peptic ulcers, by the way. NSAIDs can cause peptic ulcers. Cigarette smoking can cause peptic ulcers, can cause cancer. Crohn's disease can also cause peptic ulcer. So it's a bit less common. So all of these are important. All right, let's move on to peptic ulcers. These are important, so I'll just let you choose the answers. So NSAIDs, they have gastrointestinal side effects. They have cardiac side effects. It is a spectrum. And some types of NSAIDs are more likely to have GI effects than cardiac effects. And the other types, the reverse. So, oh, a lot of you chose B. I worry for your future. Just kidding. NSAID, okay? I'm asking about NSAID. Anti-inflammatory drug. Is paracetamol anti-inflammatory? Paracetamol is not an NSAID. Uh-oh. Well, this was tested in my exam, so hopefully I saved you a few marks. In the poll, share results. A lot of you chose B, worryingly. Paracetamol, it is not an NSAID. Remember, if you're unsure, go back to refer to my drug tables on NSAIDs. I think I will include the tables on paracetamol and NSAIDs, and also the side effects in the Google Drive later, once I reach enough feedback forms. So COX-IBs are the COX-2 selective inhibitors, and so they have less GI effects. However, as I mentioned earlier, there's a spectrum. What releases VIP and GIP in the enteric nervous system? Here. And please, if possible, message everyone. There are no stupid questions. And it will save me time to read instead of reading out the question. And I get tired. All right. Diclofenac is one of the better NSAIDs, one of the better cause inhibitors that does not cause too much side effects relatively. However, COX-2 selective inhibitors definitely are less likely to cause peptic ulcers. All right, let's continue. This is also a very important question, so I expect everyone to participate at least, and hopefully you will get the right answer as well. So basically, test positive for urine breath test and also epigastric pain. It's obvious that I'm pointing you towards Helicobacter pylori infection. So for HP eradication, what is the therapy called? It is called triple therapy or sometimes quadruple therapy. So what are the drugs that you would give? Would it be, oh, never mind, I'm just tired. Yep, it's ceftaroline, it's cephalosporin, and the rest are common drugs for HP eradication. So you give amoxicillin, which is a type of penicillin. It is also beta-lactam. You will also give clarithromycin, which is an macrolide. So like erythromycin or clarithromycin, these macrolides can be given. It is a non-beta-lactam. So you can also give metronidazole if there is clarithromycin allergy or if you can't give it for some reason, like resistance. And you should also give PPI, proton pump inhibitor, or omeprazole, or you can also give histamine antagonists to make the environment less acidic because it can worsen the peptic ulcer. So stop sharing. Here are the drugs tables: beta-lactams, non-beta-lactams. I don't have time yet. I'll try to cover the more important first, but all of these resources will be uploaded, don't worry. All right, let's move on. Colorectal cancer, carcinoma. First, an easy question just to warm up. I don't expect anyone to get it wrong, and shame on you if you do. Okay, I think you intentionally chose that, but never mind. But shame on you. Ooh. I'll just end the poll because it's too easy. Yeah, Bristol's too short. Amsterdam criteria is not for describing feces. You will learn it in clinical years. Cheshire, I'm not even sure where that is. I just made that up. This criteria, it is for actually for colorectal cancer, for describing. It's just like TNM staging. And there's the Edinburgh. I don't know. I just because it starts with E. Okay, yeah. Bristol Stooge. Anyway, let's continue. There are two main types of intestinal movements: peristalsis and segmentation. One is for mixing and churning. One is for propulsion. And just choose the correct answer. This question in particular was taken from information from Ganong Physiology textbook. For reference, I used boron and BOLPEP Physiology for renal and also gastrointestinal absorption electrolyte stuff. I also use Ganong for intestinal motility. I use Guyton for everything else. And I used Gray's Anatomy for a textbook, but also the workbook and also the anatomy dissection room. And pharmacology-wise, some of you asked whether Rang and Dell covers enough. Well, Renal does cover enough. But the flashcards, I'm not too sure because I did not use it for revision. I did not use it at all. Yeah. Okay. You cannot assess the poll. Have you tried clicking on the 3 dots on the right upper corner and then clicking poll? If you don't see it, unfortunately, then I cannot help you. But the answers are still shown, so you can still get a you'll still be able to understand. Okay, a lot of you chose D, what is correct. Used Alt and it worked. Okay. Someone said they cannot, they were not able to use the poll, but then pressed Alt and it worked. So you guys can try it if you have this problem. Yeah, thank you. Okay, so which of the following is correct? So it is not segmented. For A, it is peristalsis, which is a reflex response by distension. And for B, it should be segmentation, which is designed to stop the contents in the gastrointestinal tract to allow time for digestion, to churn the chyme with the digestive juices, and to mix it well. And nitric oxide is actually very well common. You might have already learned about it during your Sem 2 case 8 clotting factor case. NO, do you remember it? Along with prostaglandins. So nitrous oxide is actually a very potent dilator, vasodilator, anything, dilates anything. So it together with VIP does not stimulate contraction, but well stimulates relaxation. Did I get it wrong? Well, I have a table here. Let me check. NO and VIP, yes, it stimulates relaxation in front of the bolus, so the food can be pushed forward. Yeah, and serotonin, as I raised this question earlier, it is the major regulatory factor for peristalsis. All right, let's continue. This table from the information is taken from Ganong. I forgot which chapter, 25 or something. But anyway, you'll have this table in the PowerPoint later. All right, let's continue. I did not include too many questions on the movement of electrolytes in the gastrointestinal tract because they did not test me a lot in exams. However, do not blame me if they do. So accordingly, I did not put too much questions here. Okay. More people left. That's sad. All right. The answer is B. This table is taken from Borrow and Balpep, Physiology, chapter, I forgot what. Anyway, this shows the difference between the small intestine and large intestine. And the microvilli is not the major point. The major point is point C, D, and E, the absorption of different electrolytes. Please read about it. The small intestine, so in summary, absorbs water, sodium, chloride, and potassium. It only secretes one thing, HCl3, bicarbonate. Whereas for the colon, it secretes one more thing instead of absorbing, which is potassium. Okay, so it is because they have it has to absorb the other stuff to it has to create the electrochemical gradient. That's the main point. Let's continue. All right, this is a bit more distinction question because all of these are mutations that are common in the colorectal cancer. However, which one mutates first? This mutation pathway is called the APCWNT pathway, by the way, if that helps. All right, I see most of you got the right answer. Yes, it's APC. The rest is just for information. You have a similar picture in your lecture, if I remember correctly. All right. Very important and question here, so I did not make it blue. FAP syndrome, familial adenomatous polyposis syndrome, is a syndrome where there is over 100 polyps in your intestines, and it is familial. There's a gene. It is autosomal dominant, and it increases your risk of cancer. Very important. So what is the gene that leads to the syndrome? Right. APC gene, yes. So, oops. I've also, a doctor came in. Okay. Well, I hope. Okay, this is getting stressful. Okay. Anyway, let's move back. So the FAP syndrome is by APC gene. This is the thing that I would think it would be good to know in your preclinical years. For B to E, I won't expect you to know until you reach your clinical years. This is just for your reference. But at least know that for familial adenomatous polyposis syndrome, it is an autosomal dominant genetic mutation in the APC gene. All right, very important as well. True or false? A for true, B for false. Almost 100% FAP patients, patients with familial adenomatous polyposis syndrome, develop adenocarcinoma by the age of 30. That is scary. Is that true or false? A for true, B for false. All right, more than 60% answered. Let's continue. It is true, unfortunately. So it is a bit scary for patients, and a lot of patients might have to remove their resect their the deceased portion of their bowel. Yeah, so that's why it's important to know. Okay, let's move on to renal stuff. Does anyone have any questions up till now? For renal stuff, they did not test me a lot on renal physiology in exams, so I accordingly did not put too much. However, a lot of you raised suggestions about please cover some GFR calculations, explain this eGFR stuff. So I will do it later. But for now, do you have any questions regarding GI stuff? Is it worth learning the Krebs cycle and glycolysis, etc. properly? I will be covering the metabolic. I will be giving tips on the metabolic case later. Colon and small bowel both have microvilli though, do they? Yes, they do. Eh? Oh, I'm sorry. This should be the wrong answer should be A. Thank you for raising this out. Let me just type it out so that everyone does not get it wrong. Correct answer should be A. As shown in the table here from Boron. Large intestines do not have villi. Okay, thank you for raising this up. I'll correct this PowerPoint later afterwards, and you will have the correct PowerPoint when you get the resources. All right, let's continue back to renal then. First, we'll be covering acute kidney injury. So which of these are wrong concerning the causes of AKI? It was called acute renal failure in the past. It's now called AKI, acute kidney injury. But both terms are still okay to use. If you have any questions, feel free to type in the chat box. And again, let me sign out this again. All right, let's. Not a lot of you participated, still waiting, but never mind, we don't have a lot of time, so let's continue, move on. Share results. Yeah, ATN, which is acute tubular necrosis, which happens when there is ischemia, is not reversible anymore. So pre-renal is reversible, but ATN is not. So the causes of acute kidney injury can be divided into pre-renal, intrinsic renal, and also post-renal causes. So pre-renal causes mainly involve hypoperfusion of renal of the kidneys. So for example, like heart failure, or example like blood loss, hypotension, shock, all these stuff. For intrinsic renal causes of AKI, there can be like toxins, like from rhabdomyolysis. There can be toxins from like the hemoglobin released from the red blood cells. There can also be progression from the pre-renal causes to ischemia, leading to ATN. And post-renal causes would be like urinary tract obstruction, stones, etc. Okay. All right, this is just for your, this is just a fun question for information. They probably won't test you on it. This is a bit extra, but just to let you know. A patient was trapped in a building for a day because of an earthquake and developed AKI, which is a possible cause of the acute kidney injury. Could it be a fracture of the femur leading to a hemorrhagic shock? As mentioned, this would be a pre-renal cause. Could it be rhabdomyolysis? This would be an intrinsic renal cause. Septicemia, also. Dehydration, another pre-renal cause, which would be possible. Well, let's end the poll. And all of the above. Yeah. So, right. We'll be moving on to GFR calculation and also eGFR. I'll be explaining these stuff later, while following this question actually. So, which is correct? Choose the best answer. We haven't really covered AKI apart from sepsis. Well, in medicine, in exams, in order to pass, you just have to know what everyone else knows. So if you haven't covered AKI properly, then don't worry, because everyone else will not know it. But this will be just for your reference then. You can read this up during your summer to before you start clinical years then. But I think GFR should be something that you should know. All right. Share results. Unfortunately, a lot of you chose A, which is wrong. Creatinine clearance shows GFR. So eGFR means estimated GFR. I'll explain the questions one by one. B, GFR is directly proportional to creatinine concentration in plasma. That's wrong. It should be inversely proportional. So if you look at this formula, which I would recommend you to know at least, and or better if you have the mental power or time to remember it, then memorize it. This is the equation for calculating GFR. So it requires you to have a 24-hour urine collection, which is a bit tedious and difficult for some patients, which is why you have eGFR. I'll explain it later. For eGFR, I have a question. Why is A wrong again? Creatinine clearance if I measure. Well, I'm asking you to choose the best answer. So D is much better. A, it is more for GFR, not eGFR. Okay. Urea level cannot be used to estimate eGFR. I'll explain that later in the following slide. Okay, so first of all, what makes creatinine so special? Why can we use it to measure and calculate GFR? Because it is not affected by the tubular, there's no tubular handling. There's no absorption, reabsorption, and secretion at the tubules, renal tubules. It is only affected by the glomerular filtration and function. So it reflects purely the glomerular function. So we use creatinine for calculating GFR. Right, and why do we need eGFR? As mentioned earlier, GFR, we need a 24 urine collection. Here's the equation. We need the urine volume, as you can see. Collection time, urine volume. We need to measure the urine creatinine. So this requires a 24 urine collection, which is difficult for some patients. There might be problems with compliance, and so you will get a wrong calculation or measurement. So we have the eGFR, which does not require you to have a 24 urine collection. So there are very different, a lot of different formula. So for example, the MDRD formula, the CKD EPI formula, these formulas come from large cohort studies, and they use values like serum creatinine, like the creatinine levels in your plasma, your age, your sex, and your ethnicity to calculate and estimate your GFR function. They do not equal GFR. It's only a rough estimate, okay? But it is handy. Right, let me open the poll again. We're moving on to nephrotic and nephritic syndrome. A for true, B for false. Will this equation be given to us? They did not test us how to calculate GFR in our exams. So I cannot answer that, sorry. Oh, this is surprising. Results are surprising. A lot of you are choosing B, but a lot of you are also choosing A. Well, the answer is false. Nephrotic syndrome usually does not have hematuria. And also for IgA nephropathy, along with acute proliferative or post-infectious or post-streptococcal glomerulonephritis, is usually a nephritic syndrome. So I will explain more on that. For your preclinical years, I would expect you at least maybe know about the presentation of nephrotic and nephritic syndrome. That's all. Right. Yes, this one. I will have an explanation after this slide. So this is basically asking you about the characteristic of nephrotic syndrome and which one is not a characteristic. A tip, proteinuria is present in both nephrotic and nephritic syndrome. So if you have proteinuria, what will happen to your proteins in your serum? And albumin is a protein. It is normally big enough that it is not excreted. But with proteinuria, there might be hypoalbuminemia. All right, I'll be ending the poll. The results are quite mixed. A lot of you chose C, unfortunately. So I'll talk you through the nephrotic syndrome. This is quite informative. So for nephrotic syndrome, B to E are the very clinical presentation. First of all, there will be proteinuria due to various causes. So you will have excretion of protein and including excretion of albumin. So the albumin levels in your serum will be decreased, leading to hypoalbuminemia, okay? So this hypoalbuminemia actually triggers a liver synthetic function. So as you remember, liver synthesizes a lot of things like clotting factors, those vitamin K dependent clotting factors, 2, 7, 9, 10, albumin and other proteins. There's also lipids. And in the case of hypoalbuminemia, there is liver synthesis of that is triggered, and there is a synthesis of lipids as well. So you get hyperlipidemia. Okay. RAS activation is because of the hypoalbuminemia low albumin in blood. So it leads to a drop in osmotic pressure, it leads to edema, so there's ECF volume decrease, and so it will stimulate your aldosterone release, as we mentioned before in your when we were talking about the adrenals. So the one thing that stands out is isothemia, which is an increase in nitrogenous products, and is along with hematuria, proteinuria, and hypertension, is a classical presentation of nephritic syndrome. All right. Is the final feedback form for the session the same question code, the same QR code you gave in the break? Yes. All right. This is taken from Robbins. I would not expect you to know of this for now in preclinical years. This is just to let you know of the various diseases that are present that would give you a nephrotic syndrome. Here, nephritic syndrome, the classical ones would be post streptococcal GN, for example. Yeah, but this would be good to know in clinical years. So if you're interested, I can give you a session in the future. Anyway, let's continue. This is from chapter 14 of Robbins, if you want to read on it. All right, we have finished renal stuff, and let's move on with chemical pathology. Does anyone have any questions up till now? If not, I will be moving on to some acid-base calculation, just very briefly, and touch upon the metabolic stuff that a lot of you are scared about. Any questions? No. Okay. Does anyone need a break? No. Okay. Let's move on. Okay. This was tested in my exams. HAGMA, high anion gap diabetes acidosis. Anyway, HAGMA. It stands for high anion gap. So metabolic acidosis can be divided into high anion gap, HAGMA, or normal anion gap, NAGMA. And it is important that you know how to calculate the anion gap. So a high anion gap would indicate some unmeasured anions, such as ketones, lactates, alcohol, all those stuff. So in diabetic ketoacidosis, you would have an excess of ketones, which is an unmeasured anion. And so it will lead to a high anion gap. However, how would you calculate it? That is a good question. I'll give you a bit more time to calculate it. It's basically cations minus the anions, if you're wondering. The reference value is around 7 to 17. But they did not give me that in exams, so I am not giving you this in here right now. All right, let's stop. We don't have much time. The answer is D. Unfortunately, a lot of you chose B. So here's the equation. You just have to calculate it. If it is larger than 17, then it is a HAGMA. And what causes HAGMA? Basically, high anion gap, which suggests unmeasured anions. So the anions that we measure are, the main ones are bicarbonate and also chloride, okay? If there's a high anion gap, there would be other anions here, ketones in particular for your DM case. And there are a lot of causes for HAGMA, and there's a mnemonic called Goldmark, just help you remember what can be the causes, basically. So notable causes for you for now would be methanol poisoning, aspirin poisoning, renal failure, and ketoacidosis. Right, let's continue. All right, we are going to, I do not have any questions prepared for you about the metabolic pathways, because I do not remember them testing me, and I'm not sure how they would test me on that. However, I did just like to give you some tips on it. So this original flowchart was taken from Dr. Thomas News, my PBL tutor, the lecturer who should have taught you the metabolic pathways. So how I revised for that was I printed this out and I just basically wrote everything that I found important in the lecture into it. So this is basically the summary of all the metabolic stuff. And it is a bit blurry, but I have a clearer version on the Google Drive. Wait, that is a question. Is the NN-GAP an equation you need to learn? Well, you need to learn it anyway. In the future, it is very easy. Just sodium plus potassium minus chloride, and did I write it wrong? Oh, I wrote it wrong. Sorry, HCO3. Yeah. I would say this is a important equation to know of. What are the equations relevant for this exam? NN-GAP for one. GFR might be one. What else? I can't think of any right now. I'll let you know if I can think of others. There's not much calculation in my exam. In the exam I had 2 years ago. Okay, let's continue with the metabolic stuff. Okay, so it's important to know of the processes. So here I've listed all of those important processes: glycolysis, glycogenesis, ketogenesis, all those stuff. This is more for helping you understand the pathophysiology of other diseases. For example, let's look at here, the yellow highlighted here. Ketogenesis. There will be acetoacetate and also beta-hydroxybutyrate produced. These are metabolites from ketones. And when we check for diabetic ketoacidosis, we would do urine dipsticks to check for ACAC, so acetoacetate. We will also check plasma beta-hydroxybutyrate, and these would indicate DKA or keto, high keto levels. Anyway, so these are actually to help you understand the other pathophysiology stuff. For another example, GLUT2 and glucose, or maybe you need to know about the fructose 1,6-bisphosphonate. That's quite a important thing because that's the point of no return. You can't go back. It's not reversible anymore. What else would be useful to know is maybe at least know what each process means. For example, glycolysis would mean lysis of catabolic breakdown of glucose. PFK1 and 2. Is that important? I don't even know what PFK1 and 2 is now. I won't say it's important, but don't take my word for it. They did not even test me on much on metabolic stuff anyway. All right, let's continue. We're almost there, almost the end. We have 198 slides. We're almost ending. So urology, mainly BPH. Does anyone have any other questions? If not, I'll continue. We still have half an hour till our scheduled end. Right. Which of the following statements is wrong? Please read carefully. What is BPH? Have you guys learned about BPH already, or have you not? Raw is this week's case. You have not done it yet. Oh, well. Just treat it as something that helps point out the important stuff anyway. Okay, then I will skip the polls. I'll just directly share the results and give you the answers. All right, BPH. Some call it benign prostatic hyperplasia. Some call it benign prostatic hypertrophy. I'm not sure which one is the correct term. But anyway, there is both hyperplasia and hypertrophy. So it happens in the central zone and transitional zone of the prostate. the prostate is divided into the central and peripheral zone. And usually for cancers of the prostate, it is in the peripheral zone, while for the central zone, it is usually where BPH occurs. And then I've put in some histology and growth specimen, probably not important for exams. And so there is hyperplasia of your glands and also hypertrophy of your muscles. So it leads to an enlargement of your prostate gland. With the enlargement of your prostate gland, you will have obstruction of your urinary tract. And that is inevitable scenario waiting all the males out there, because whether you want it or not, you will eventually get enlargement of your prostate. It is just a matter of time. So treatment for it, why do we need to treat it? Because it can cause acute urinary retention or other lower urinary tract symptoms, LUTs. So how do we treat it? We treat it with alpha blockers and also 5-alpha reductase inhibitors. These are the two drugs that you should know of for your coming case on BPH. The alpha blocker works on the dynamic component, which is the urethral sphincter. It makes it relax. The 5-alpha reductase inhibitor works on the static component, which is inhibits the conversion of testosterone to DHT, an very potent androgen that can stimulate and worsen BPH. Apart from pharmacological treatment for BPH, they can also be surgical. For example, transurethral resection of the prostate. So basically resection of you remove the prostate. It can also be ultrasound or laser therapies, which won't be important for now. It is notable, but not important for your case, the symptoms of BPH. You probably won't be tested in preclinical, but I thought you learned it already. So I'll just show you the answers actually. So it is getting a bit more teaching rather than a mock exam, but never mind. BPH is just one of the many disorders that male or females can have. So well, obviously females don't have BPH, but anyway. So LUTs, what does LUTs stand for? LUTs means lower urinary tract symptoms. It can be classified into 3 types: storage LUTs, voiding LUTs, and a distinct category of its own, nocturia. Storage LUTs refers to urgency, frequency, and incontinence. It basically means your bladder is storing too much urine, and so it keeps stimulating you keep wanting to void. Like you have no trouble voiding, but you just have too much trouble. You have too much storage of urine. Okay, so what happens will be urgency, frequency, and incontinence. For voiding LUTs, it means that there is a problem with voiding, which is just a posh term for urination. So many causes, including BPH or like cancers of the prostate. So anything that blocks your urinary tract will cause some voiding symptoms. And these are this list are the symptoms. Yeah. So just when you start the case, just go back to this PowerPoint and refer to it. All right, let's continue. I think we can try this poll. Does BPH lead to increased risk of cancer? Yes or no? We might overrun by like 5 or 10 minutes. I hope that's fine with you guys. All right, let's move on. A lot of you chose true. However, it is false. It is a benign prostatic hypertrophy or hyperplasia. There's no association with cancer, fortunately, for males. Because if it has association with cancer, well, it would be very unfortunate to be a male. All right. Oops, I showed the answer. But anyway, let's just show it. So PSA is something that you would measure for stuff regarding the prostate. The full form refers to prostate specific antigen. So as its name implies, it is specific for prostate tissue. However, there are a lot of factors that can cause an elevation of prostate levels. And all of these are causes. So there can be benign causes like benign BPH, prostatitis, which is an inflammation of your prostate gland, urinary tract infection, or some malignant causes like prostate cancer, or some iatrogenic or some procedural causes like prostate biopsy. So anything that irritates the prostate can cause elevation in PSA. And so it is not cancer specific, but it is prostate specific. Okay, and there's this thing called prostate health index. There's an equation for it that we can use to improve the diagnostic performance, but don't bother with it too much. All right, as you have not learned the prostate yet, I'll just skip this. It basically want to illustrate that there are different age-specific reference intervals for PSA, and as you can see, the reference intervals increase with age. That's mainly because we also have prostatic enlargement anyway with age. Yeah, okay. You don't have to know the reference intervals. Definitely no. All right, we're almost there. BSS, biosocial science, ethics and law, evidence-based medicine. Does anyone have any questions regarding the physiology, clinical stuff, pharmacology? If not, I will move on to the last section. I think we might be able to end on time, actually. Good time management on my part. All right. Paul, cage questionnaire. I hope you learned it already. Please, can we have a 1 minute break? Sure. I'll give you some time to answer this question as well as a 1 minute break. Do we need to know about UC and Crohn's? Let me post your answer out, your question out. Please, guys, can you like type the answer questions to everyone in the chat? First of all, UC, ulcerative colitis, and Crohn's disease, they are what we call inflammatory bowel disease. And secondly, unfortunately, Crohn's is not spelled like that, as it says. I hope it was just a typo, but do you need to know a lot? It was not tested in my exams. It was not in the learning agendas that I had. But if you have time, obviously, it would be good to know for your preparation of clinical years. But for exam-wise, in pre-clin, I would not say you need to focus a lot on that. Please, I'll give everyone a 1 minute break. So in the meanwhile, I'll just answer the cage questionnaire. Who keeps asking for 1 minute breaks? I'm well, patient privacy. All right. Do you need to know about hernias? I would say yes for clinical years, but definitely not for preclinical years. Oh, wait, sorry. But you will briefly touch upon hernias when you are learning about the inguinal canal, all the stuff, I think. But if it is it important, I would say not as much as the other stuff that I quizzed you on just now. All right, let's start. What does A in case questionnaire stand for? A lot of you chose annoyed, and that is correct. Just briefly, so C means have you ever felt that you should cut down your drinking? Cut down your drinking. A means do people annoy you by criticizing your drinking? G is do you feel guilty about it? And E is eye opener. So do you have to the first thing in the morning? Do you have to quickly go and drink that alcohol or stuff like that? All right. This is an extended matching question, so which means there's a part 2. Hard questionnaire. This is another questionnaire for a completely different purpose. Could you give us a brief list of which diseases we need to learn in detail? Well, the diseases that you've covered in your PBL, I would say, obviously. Refer to your intended learning objectives, ILOs. We have a lot of time. Yay. So hard questionnaire is basically to identify some women who have been victims of abuse. And here it is. Humiliation. Were you ever humiliated by a partner? Were you afraid of him or her? Were you raped? And were you was there physical abuse? Yeah. So basically that's it. Share results. And most of you got it right, which is good. Let's move on. This is something that they like to test us every year in progress tests and was also tested in semester tests. And it's pretty common sense. For some reason, they don't teach you that, however, but they still like asking you on it. That's why I don't like BSS. They don't teach you and they expect you to know it. All right, yep. Most of you got the right answer. Physician driven. Just read about the others as well. Make sure you understand. All right, a bit of a tricky question. I'll give you a bit of time, at least a minute to calculate it. But because I think a lot of you haven't started revising EBM yet, I'll just give you the equation here. One thing that I did not cover in this mock exam was Barrett's esophagus. It might be good to know what type of epithelial changes is there, and its association with cancer. It might also be good to at least know of the other dysphagia causes like achalasia, strictures, web formation, esophageal cancer. Yeah. And it would also be good to know about briefly varices, because that's a very serious medical emergency. So when you cover for example, the blood vessels of the gastric of the stomach, which vessels are likely to rupture and all those stuff. Yeah. All right. Only 18 of you have participated. Should I give you a bit more time? Yeah, I should. I'll wait until like maybe at least 30%. By the way, they did test me this on exams. It was this was only like one part of the whole EBM question. They tested me on false positive rate. They tested me on prevalence. So when you go back, you can try, I don't know, calculating the rest of the stuff. make sure you understand what specificity and sensitivity means. One means that how sure you are that how sure you can tell the patient that they don't have the disease. One is how sure you are to tell the patient that they do have the disease. Just make sure you get it right. Do you need to know all about portal hypertension related pathologies like hemorrhoids? Wait, hemorrhoids? Portal hypertension. Does it called hemorrhoids? I did not even know that. I did not even know that hemorrhoids are associated with portal hypertension, actually. Okay, a bit. Okay. Well, if for your preclinical exams, I would focus on the most important diseases. Hemorrhoids probably less important. In medical school, when you're like still a medical student, you're just learning how to not kill a patient, basically. Once you make sure that you will do no harm, then you can start learning how to help the patient. And for hemorrhoids, it's hard to really cause mortality. So if you have time, well, by all means, go and read about hemorrhoids. But I did not. Okay, let's end the poll. 18%. I already gave you the equation. Just go back and search. This is just taken from my forgot wiki or something. Taken from a paper or something. I forgot. Just basically throws all the equations for calculations. All right. This is probably the last question. The second last. You might have learned about the DVLA already in semester 3. But this was tested again in semester 4. So I thought you would just want to try it. DVLA is like driving license thingy agency or something. You have to inform them and you cannot drive for some specific conditions. So I might going back to the slide quickly. You can just go back and refer to the whole PowerPoint. You will be given the PowerPoint as soon, so don't worry. All right, DVLA, yes, everyone got it right. Almost anyway. The patient has to inform the DVLA for themselves. Yeah, 18.8 was the percentage. All right, as mentioned, yeah, this was the last question. So all of the resources, all the notes, all the mind maps, and all the tables I made for you guys will be uploaded to the Google Drive. You might already have access to the Google Drive. However, you don't have access to the folder. I will be unlocking it once I collect enough feedback forms, which is the number of registrants, which is around, which is over 200 last time I checked. Well, it's 213 now. I will unlock it when there is like 200 responses, and I will also I will send out the recording. I will post it to YouTube or something, to the rest of the people, to all the registrants, and when I have enough feedback forms, like 160, yeah. All right. So. Thank you very much for attending the session. This is not the last slide, however, I still have one more slide at the back, so it would be great if you can stay a bit. So first of all, thank you for attending the session. Here's the QR code for the feedback form. Please fill it in. It helps me a lot. This is the only thing that I ask for you for this session. And it will help me improve as well. So I will send out the recording when the number of participants that attended the Zoom meeting, which is 160, filled in the feedback form. I will send that video. And when everyone has really attended this lecture session, including the video, those watching the video, and filling the feedback form, at least 200 feedback forms, I will release the PowerPoint and resources. I will unlock it. Yeah, so just a few words before you leave. This is this might be the last session that I have with you guys. You guys are going to clinical years, and I left Manchester in after my preclinical years. So I'm not sure. Well, I'm not familiar with your examination, like your contents. However, all diseases are the same in the world. All the skills for history taking, physical examination, all the skills for lab report interpretations, chemical pathology, all of those are the same. And you still have to learn more about the disease pathophysiologies in clinical years. So I can still teach you that. And if you guys want, just make sure you click the yes button in the feedback form. And if I get enough responses, then I can. Yeah. So good luck. Someone raise your hand. Okay. Well, you raise your hand. What can I ask why? You can unmute yourself if you want. Could everyone present right now? Just fill in. This was the question I had. Could everyone present right now just fill in the feedback form right now, and you send the resources to it right now, please? Well, let me see how many feedback forms I have collected right now. Because I would like to make sure that even the people who had to leave early, or those who did not, who were busy or could not attend the session in person, at least I want to make sure that they watch this video before I really release the resources. And the resources are very, very useful. I would tell you, I can tell you for that. So if you know anyone that registered but did not attend and have not filled in the feedback form, tell them to fill it in. Yeah, that's all I can help you with that. If I don't receive enough feedback form, unfortunately, I won't release it until. Oh, okay. When are your exams? When are exams? If I still don't have enough feedback forms, I can still release it maybe a few days before exams. Okay, 23rd. Okay, I will release the resources by the 20th of May if I still don't have enough feedback forms. Please release it ASAP. Well, please fill in the feedback form ASAP. I do not do it for money. Thank you, but no. Could you release it a week before if possible? Well, if the feedback forms I collect do not have 200, maybe 180, I will. Okay, I will release a week before. Arabian Twins. So well, thank you, but I'm satisfied with what I have right now. Thank you. Right, so that's all. Do you have any questions? If not, well, good luck with your exams. I'll stay for 3 more minutes. Remember to fill in the feedback form. I just posted the feedback form for you here as well in case if you want. I will also send out the feedback form to all the registrants after this session. Hello to the person who entered just now. Unfortunately, we are ending. We have ended. Yeah. All right. No one seems to be asking questions. I'll be leaving then. Ending the session. Thank you. Yeah, you're really early, Ali. Oh, and if you know any like year 2 to B, well, please help me recommend my sessions to them in the future. Anyway, see you.